Hi everyone, I'm Dr. Rezaian, a specialist in rheumatology, and welcome to the channel. Today we're going on a full tour through the treatment of rheumatoid arthritis, starting with conventional DMARDs, moving through biologics, and finishing with the latest targeted therapies like JAK inhibitors. Before we begin, this video is for education and inspiration only. It's not medical advice. Be sure to consult a healthcare professional and double-check information with trusted sources. Rheumatoid arthritis is a chronic autoimmune disease that leads to persistent inflammation of the joints. Over time, if not treated properly, it can cause joint destruction, deformity, disability, and systemic complications. Treatment goals include reducing inflammation, preventing joint damage, and improving function. And the tools we use are DMARDs, disease-modifying anti-rheumatic drugs. First up are the non-biologic DMARDs, the traditional foundation of RA therapy. Methotrexate is the anchor drug, usually dosed 7.5 to 25 milligrams once weekly, taken orally, subcutaneously, or by injection. Folic acid supplementation, 1 milligrams daily or 5 milligrams weekly, is required to reduce mouth sores and other side effects. Labs like CBC, liver function tests, and creatinine are checked every 2 to 4 weeks initially, then every 8 to 12 weeks. Leflunomide is given daily at 10-20 milligrams, sometimes preceded by a loading dose. Side effects include diarrhea, hepatotoxicity, rash, and teratogenicity. It requires monitoring of liver enzymes and blood counts. Sulfasalazine, titrated up to 1,000 milligrams twice daily, is safe during pregnancy and helpful in combination. Hydroxychloroquine, dosed 200 to 400 milligrams daily, depending on the is often used in milder cases or alongside other DMARDs. Regular eye exams are required after 5 years of continuous use to monitor for retinal toxicity. When conventional DMARDs aren't enough, we turn to biologic DMARDs. These target specific components of the immune system driving the inflammatory response. Etanercept Imbrel, 50 mg subcutaneously once weekly. Adalimumab Humira, 40 mg subcutaneously every other week. Infliximab Remicade, 310 mg in IV at week 0 to 6, then every 6 to 8 weeks. Golimumab, 50 mg sub-Q monthly or 2 mg per kilogram IV every 8 weeks. 400 mg sub-Q at week 0, 2, 4, then 200 mg every other week. Before starting biologics, every patient should be screened for latent tuberculosis, hepatitis B and C, and HIV, and be up to date on vaccinations, including influenza, pneumococcal, shingles, HPV, and COVID-19 vaccines. Tocilizumab, 4 to 8 mg every 4 weeks. 62 mg weekly. Saralimumab, 200 mg sub-Q every 2 weeks. These medications can raise cholesterol, liver enzymes, and risk of GI perforation. Labs should include CBC, LFTs, and lipids. Abatacept, I4 500 to 1,000 mg weight-based at weeks 0 to 4, then every 4 weeks. 1 in 25 mg weekly. Abatacept is well tolerated and may be preferred in patients with chronic lung disease or multiple comorbidities. Rituximab, dose 1,000 mg IV on days 1 and 15, repeated every 6 months. It's highly effective for seropositive RA, those with rheumatoid factor or anti-CCP. Pre-medication includes steroids, antihistamines, and acetaminophen. Hepatitis B reactivation is a concern, so screen carefully. Anakinra, dose 100 mg sub-Q daily, used far less commonly in RA and typically reserved for refractory cases or autoinflammatory overlap syndromes. These oral agents are powerful and fast-acting, but they come with some serious safety considerations. Tafasitamab, 5 mg twice daily or 11 mg once daily extended release. Baricitinib Olumiant, 2 mg daily adjusted for renal function. Upadacitinib, 5 daily. These medications inhibit JAK enzymes that transmit inflammatory signals. Risks include blood clots, cardiovascular events, and certain malignancies, so they're used with caution. Monitoring is key with all these medications. Here's what we check. CBC, LFTs, creatinine every 2 to 4 weeks initially. Lipids, especially with IL-6 or JAK inhibitors. TB and hepatitis at baseline and recheck if risk reappears. Eye exams if on hydroxychloroquine for over 5 years. If you develop a serious infection, the biologic or JAK inhibitors should be paused and you should seek medical care immediately. While on biologics, live vaccines should be avoided, and all recommended vaccines should be given before starting therapy. That wraps up our full review of rheumatoid arthritis treatment, from non-biologic DMARDs to biologics and targeted therapies. With the right monitoring and an individualized approach, remission is absolutely within reach. If you found this video helpful, be sure to like, subscribe, and share it with others. I'm Dr. Rezaian. Thanks for joining me, and I'll see you in the next one.